So welcome to Scotland, Ramona. It's our pleasure to have you here with us. And can you tell us a little bit about why you have come to Edinburgh today?
Sure. I'm happy to be invited by Care Not Killing. And I was asked to come today because I'm a family doctor who works with marginalized patients, people who find themselves in lower socioeconomic situations, many refugees, gentlemen who've been incarcerated or are facing prison charges, and basically marginalized populations. And I'm very concerned about what I've seen in Canada unfold and the risks that assisted dying actually poses to vulnerable persons.
Thank you. And not everyone will necessarily know about the legislation in Canada or in other countries. Can you just give us a little bit of insight into what exactly assisted suicide is, what euthanasia is, and how the legislation has developed in Canada just over the last few years? Just give us a little bit of a flavour for what has happened.
Sure. So medical assistance in dying, which we now call MAiD, applies to both terms, assisted suicide and euthanasia. And although these are distinct procedures, I would say they're ethically the same. They're ending the life of a person with the participation of someone else. Euthanasia is when a practitioner administers, usually IV drugs, by the bedside to end the life of the patient. Assisted suicide is often when a doctor gives a prescription to a patient who then goes and fills a lethal cocktail of drugs that they take home or take in some other venue, but it's self-administered.
Oh, thanks, that's very helpful. And for those who are listening from Scotland, they may know we currently have a bill in the Scottish Parliament that is proposing assisted dying, but that's particularly referring to assisted suicide, although there is some concern that there might be an extension to euthanasia. So this is very relevant to us here, and thank you for explaining. Can you tell us a little bit about how things have developed in Canada over the last few years?
Yeah, so when they rolled out in 2016 the initial legislation, it was supposed to be very similar to a lot of initial bills. The term was for the broad end of life context, not different from the Scottish bill and other assisted dying bills that are being proposed in other jurisdictions. And very quickly, we had some safeguards. They were dropped. MAiD was expanded to people with disabilities who were not dying. It now includes legislation has passed for it to expand people with mental illness, the sole medical condition of mental illness in 2027. And we are debating a bill for advanced directives for dementia, for medical assistance in dying, and there is a recommendation that we should expand to children. So I think that quickly illustrates that in a very short period of time, whatever safeguards we had in our legislation have completely degenerated as our society kind of moves, like you can see on the slide, from this, this is going to be an exceptional measure. An exceptional measure where we were told it would be 100 requests a year, and that no one would have a wrongful death and there would be safeguards to protect everybody. And then as soon as it passed, it moved to be promoting of patient access. So safeguards that were initially told would essentially be there were removed because they were barriers to access. Exceptional measures became, though this is about choice. This is not exceptional. I want it and I want it now. And selection criteria like end of life. Well, why can't someone who's suffering from mental illness or disability or homelessness or other social issues be granted assisted suicide as well?
And can you just give us a sense? It was promised that it would be very few and exceptional cases, which we can understand that it's often asked for the very exceptional cases. Just in terms of what's happening in Canada, roughly what are the numbers now across Canada?
Yeah, it's quite shocking. So 2021, so we legislated in 2016. By 2021, we were over 10,000 deaths. The next year, 13,000. This past year, it looks like we're at 16,000. So you can see Health Canada has called it growth. This is not growth. This is a 30% and 20% yearly increase is terrifying. And some areas of Canada have approaching 7% of all deaths being MAiD deaths. And if we were to count it as a cause of death in Canada, which Canada refuses to, it would easily hit it higher up or mid in the top 10 reasons that people are dying. In fact, there are 2 end-of-life commissions that study medical assistance in dying in Canada and the patients that might be affected. So you would think that every jurisdiction, every province does, but most provinces do not have a robust system. And actually, in my province, I am part of a MAiD death review committee, and our coroner, who chairs that committee, released at a conference last month, he highlighted that even for reasonably foreseeable death, for the end of life criteria, there's a high rate of people who are living in residential instability and material deprivation. And even higher, something like 75% are in the lower half of society when they do not have a reasonably foreseeable death. So it's showing that there is a real risk to people who find themselves at the margins of society, people that we failed with poor social policy or as a society have failed to include in community. And in Quebec, the End of Life Commission published in August of 2023, Michel Bureau sent a warning to MAiD assessors and providers that MAiD, one, people that there's an increase in non-compliance with the law. People are being approved on old age, which was never part of the deal. That and that doctor shopping is not an option, so that people are just going to see doctor after doctor until they get approved. And he said, actually, in an interview, I think I had mentioned that we were told this would be an exceptional treatment. And Michel Bureau said, I have the quote here that I'd like to share, "We are no longer dealing with an exceptional treatment, but a treatment that is very frequent." And think of the words, a treatment.
Yeah. And I think that to me sounds just like a whole culture change in medicine as well, to talk of death as being a treatment, which is a very different way of looking at things, isn't it? And a different way of managing things. And I suppose one of the things that people often say is that this is a choice, that people have a choice, and we ought to honour that choice. But I guess what I'm concerned by, what I'm hearing from the situation in Canada, is that maybe choices are clouded by lack of access to care or lack of access to social care. Is that fair, or is that
absolutely fair? So no one's choices are made in a vacuum, right? We are always influenced by those around us and what life has dealt us. And so I understand that DID is doing exactly the same kind of promotions that they did in Canada by saying this will be exceptional. This is about compassion. This is about autonomy and choice. When actually now that same kind of, not DID, but it's kind of sister group in Canada, is wanting MAiD for children as young as 12. They want MAiD for people who will have lost their capacity. They want to have advanced directives. So their messaging has really changed from what they started, but it sounds like they're starting with the same kind of campaign in Scotland that they end in some of the other places like Isle of Man, and I presume in Westminster soon, that they used in Canada. And in fact, in many cases, but actually I showed you that there are actual trends of people receiving medical assistance and dying for things like poverty, neglect, long waiting lists. One MAiD provider said that she would end the lives of people. She said this in Parliament, I'd end the lives of people if they're on a long waiting list because they're suffering. And so when suffering becomes a treatment that must be delivered immediately to alleviate suffering, when there are inequalities in society for many reasons, but waiting times for care can demoralize people. And so you can have people who are demoralized, actually worn down by society, who are choosing medical assistance and dying. That is the opposite of choice. That is being driven to death by structural inequality, and I could say coercion or unfair influence. That is not an autonomous choice.
I absolutely agree, and I think what we're facing in the UK at the moment is real problems in our healthcare system, and uh, we know that about a quarter of patients don't access the palliative care that they need. So the ability to make a choice is not a true choice if you don't aren't able to compare those two. In your experience, can you think of or draw on some experience of how patients have been affected by MAiD? Can you think of
Yeah, I'd like
situations that you
to,
were concerned about?
I mean, I shared some trends, but I think what's very important for people to hear is to understand how close this can hit to home. You know, as initially, like in this debate, many people kept their heads down thinking it wouldn't affect their families, it wouldn't affect their parents. But actually, when these legislations pass, they affect us all. That's what public policy does. And so I'd like to share the story of Donna Duncan. And I do recommend that everybody watch Liz Carr's Better Off Dead documentary. I think it's a
Yeah,
very powerful documentary. She does come to Canada. She does film a palliative care doctor in the United Kingdom who does a very good job of expressing her concerns. I think everyone should watch Better Off Dead. But this is Donna, and I am in touch with Donna's children, Alicia and Christy. Donna was in a skiing accident. She had a concussion during COVID. It took over a year to receive specialized concussion clinic treatment. In the meantime, she became extremely depressed, according to the daughter. She was not eating. She received medical assistance in dying within 4 days of her first assessment. And her poor daughters are so devastated. They are in the Better Off Dead documentary as well, but they're left with no answers. The hospital won't tell them. Their mother, they didn't know she had a terminal illness. We presume that because Donna was depressed and not eating, that they said that her death had become reasonably foreseeable because she had made herself sick enough to die. And so they ended her life through medical assistance in dying. So a family left with no answers and grieving. Similarly, Alan Nichols, if I could share his story, I also know Gary and Trish. Alan had a history of depression, but he always recovered. And a neighbor called for a wellness check. I'm not sure if you guys have the same kind of thing here. When we think someone's in danger, we call a wellness check. So the police went and thought, okay, Alan is not taking care of himself. They involuntarily admitted him under our Mental Health Act to save his life. And he called Gary and Trish and asked to come home. And they said, you know, you're safest in the hospital, Alan. You should stay there. Well, Alan, during this admission, later in this admission, was given medical assistance in dying. And the family was noted very little time. They couldn't change anything. Also, we had no terminal illness. They also have no answers. And so you see all these kind of grieving families who are also victims of this public policy that affects everybody. And, you know, both the Duncan girls and Gary and Trish didn't have a problem with assisted dying policies. They actually thought it was good when it was proposed, and exactly what you said, that it would be a compassionate act that would be used for choice. And both of them understand now this is not about choice. This is catching somebody at their lowest, seeing them as perhaps having an expendable life and helping them on the way out when they really needed hope and recovery.
yeah, those are shocking examples actually, just to think how we as a society respond when people are their most vulnerable. It's just, and I think you're right, absolutely, about how it affects all of us. It's not just an occasional people, and public policy affects all of us and all of medicine. And I'd be interested, how do you think it affects clinicians, doctors, nurses who are involved in this? Are they supportive, or are they concerned, or?
You know, it's a very good question, Gillian. Like initially you have all the palliative care and chronic care doctors who understand recovery, strongly fighting these bills. And you have a lot of the acute care doctors stepping in to be MAiD assessors and providers. In the meanwhile, you have the medical schools kind of indoctrinating your young students so that like the second generation of MAiD providers are family doctors and some palliative care doctors, although the philosophy of palliative care and MAiD are the opposite, right?
Yeah.
And so what I would say is, what does it do to the medical profession? I would say it wrecks it, because the medical profession, part of our ethics and understanding is that when someone is self-loathing, when someone doesn't feel that they're good enough and don't want to carry on, we offer solutions of hope. We look for creative solutions, different solutions, medical, social, spiritual. A doctor should always be there to affirm to a patient that their life is worth living. And yet, with medical assistance in dying, you have now this kind of subtle kind of messaging and indoctrination of the healthcare system that actually some people's lives are not worth saving, and that maybe they are better off dead. And then what that can do is it corrupts our ethical principle, our core principles, because it allows unconscious biases against people to creep in. Well, that person who's over 80, well, that person who I would never want to be like, oh, that person who is Indigenous and alcoholic. Maybe these are the people that when they're asking for death, it would really be a mercy to end their life. And so you start to see the splitting in healthcare of people who are considered valuable and the people who are considered not valuable. And that's extremely dangerous. My father has dementia. He lives with me. He has about a 30-second loop. Like, hi, Ramona, you're my daughter, my sister, he can't remember, but he's always happy. And he's still my father. I cannot explain all the ways that he is the same man, but I'm scared to take him to the hospital by myself now. Like, I don't leave him for a second. I sleep there overnight because I don't feel safe. I'm taking my father to receive care because I know that other people look at my father and don't see my father. They see a demented old man who doesn't seem to really catch what's going on. And the disability community has said that over and over again. They're no longer feeling safe. Like, they already had so many obstacles to good care. Right? Ableism exists. Physicians are a product of society. And so many physicians, whether they realize it or not, carry these unconscious negative biases against people with disabilities. In fact, we have studies that show that they rate the quality of life of people with disabilities and dementia as quite low. But if you actually look at patients' ratings of their quality of life, they're the same as HMAF healthy individuals. We've had many people who are like, why is this? They don't know what they're doing. They're just not willing to accept the fact that it's their bias that makes them see them as lesser, when actually they are equals and equally able to have the same quality of life if we let them, if we give them their supports, if we love them, if we include them in community life. And so I think MAiD has really destroyed our medical culture, and I don't know how we'll recover, because we have younger generations who might have never seen a good palliative care death, but have seen MAiD. I've been told that some of them have to witness MAiD to graduate. That's indoctrination.
And just in terms of choices for the doctors, can doctors opt out, or do you have to opt in? How does it work?
Yeah, so we were told, and I think it was to keep us quiet, that we wouldn't have to be involved with MAiD. MAiD would be this thing that happened over there. And there was a conscience clause in the bill that said that no doctor would be forced, or healthcare provider, I think it was a doctor or nurse practitioner, would not have to assist and provide. And again, like I said, how the bill had this kind of not strong wording, and potentially it was purposeful, like your Scottish bill, and I'm sure other bills. Isle of Man is 12 months prognosis. That's like, there's a lot of uncertainty in a 12-month prognosis, right? So the more uncertainty you can build in the bill, then as soon as it passes, like in Canada, they said, oh, actually, we meant you don't need to provide or assist in the room. That's what we were talking about. Yeah, you have to inform patients. You need to make a referral. You need to connect them to a MAiD provider. And so what's happened in Canada is you have doctors who are very demoralized, very distressed. Like, we love our patients. Who wants to send them to have death when we know that they're waiting for care? And then you have, on the other hand, even MAiD providers who are distressed. There was Alex Rakin did an article, No Other Options, and you can look at the videos. But one of the MAiD providers is saying, what if I don't feel comfortable because I feel like MAiD is driven by homelessness? And the ethicist responds, well, then you'll make a referral to another doctor who will hopefully do it. And so if a doctor doesn't exercise their conscience in every act, they are not serving the patient. Like, would you trust a doctor who did not act in your best interests every time? So when we're forced to make a referral, if we comply, it's really to the detriment of our patients. Conscience rights are important for our patients. and yes, they diminish moral distress a bit, but we're still morally distressed. So it's not worked out the way we thought it would in Canada.
Yeah, I mean, I think that's really important. Certainly, we know that palliative care doctors are very opposed in Scotland, and 40% of them said that they would leave palliative care if this came in, and that is hugely to the detriment of patient care, because
Well,
we
I hope
need,
they do it.
yeah.
I hope they do it. They don't think like what happened in Canada is most of us just put our heads down. I hope they do it. I
It's so difficult, isn't it, when you're reassured and then it changes to something else. How do you think it has affected hospices and palliative care, but probably, or more widely, medicine as a whole? How do you think it has affected the provision of care for the dying?
I do think palliative care were the first like canary in the coal mine in Canada. And so the impacts on palliative care were quite heavy. The government bundled end of life care together, like medical assistance in dying and palliative care. A lot of the nurse practitioners who had been trained in palliative care were tasked with doing medical assistance in dying in the community. A lot of their time and administrative time became used up for medical assistance in dying. So we have even less palliative care, even though we already only have like 15 to 20% of people dying with good palliative care in our population. We've had even less of that. You have places like Delta Hospice, which lost its funding. So it had fundraised its own building. Like this is donors who'd given to Delta Hospice. And Delta Hospice had a non-religious creed because they were trying to be open, and that was the plan, right? It was a local community initiative. But they refused to do MAiD on their premise because it is incompatible with the philosophy of palliative care. And they are correct. That is what most world organizations would say. But Fraser Health Authority stripped them of their building, kicked them out, took over the hospice, even though the hospice was literally, I don't know, a 1-minute ride to the hospital. So this is much more about wanting to, people tell me, oh, I think we can coexist. And I want to tell people, like, you're naive if you think that that's what's going to happen. That's not what's going to happen. And as palliative care and medicine gets funded less, as things get, and MAiD gets funded 100% in our country, then you have a worsening of care. You have a perverse disincentive from the government to not fix the problems in social and health policy, and everyone loses.
Yeah, it's so difficult. I mean, for example, the Scottish bill is being proposed to be led by GPs, by general practice, and I think many GPs will just feel it's impractical. How can we possibly deliver that? Not alongside the fact of not wanting to participate, but how can we deliver that in a stressful job already? Can you tell us a little bit about the delivery of MAiD situations? Certainly heard of situations when assisted suicide goes wrong, those sorts of situations that are concerning.
Well, we are 99.9% euthanasia. For sure in other, and Joel Zavat, who is an anesthesiologist, has looked at, he did an FOI, a Freedom of Information, and captured the information on autopsies of people who had been through capital punishment. So this is different, this is States. However, they use the same medications. And he's very, very concerned. He actually spoke in Danny and Prue's, what's it called, Road Trip, their documentary.
Yes, I remember.
So you could look at that, but he shared about how, first of all, he was concerned about these prisoners who were dying through horrible deaths, like drowning. But these are the same meds that we use for medical assistance in dying in Canada. So he actually shared in parliamentary testimony in Canada that we actually have no evidence. We've not been doing autopsies. We've not really been doing toxicology. The coroner collects some of the blood samples, but actually has never run them. And if there is autopsy information, it's not public. So we don't actually know if people are dying. I mean, I think this is, there's a lot of more important issues, but actually it is true. I don't think it's a good death. We give a paralytic, so we can't even tell if the person is suffering or not. Everyone's like, oh, they look beautiful, they're paralyzed. You wouldn't tell. You
Mm.
know, Joel said that in the States, often you see these prisoners like clenching their fists or clenching the chair, which is why you got concerned in the first place. So there's a very possible, it's very possible that it's not a painless death.
We
But
just
I
don't
think
know. Yeah.
I
Yeah.
think if you focus on that, then you're like, well, we'll just develop new drugs. I mean, there's lots of other very important issues at hand.
Yeah. And I suppose one thing would be, where is all the regulation around this? Why are all these things happening? Why is regulation and safeguarding not working for Canada?
So, okay, first two things. One is that just because your bill is more assisted suicide and it might be more assisted suicide, there is actually a lot of evidence, or there's no clinical trial evidence, but there is, in terms of collection of data, we know that I think 7% of cases, people take 6 hours to die, up to 137 hours to die when self-ingesting pills. So just to answer that question, just because it's not relevant, so relevant to Canada, we don't have the data reported, but we have that data in Oregon. Then in terms of why are the safeguards failing? So medicine did not invent ending people's lives. This is like an age-old ideology that keeps resurfacing and was inserted into medicine through lobbying.
Yeah.
And so it doesn't have the medical research in terms of even if it is safe. It's like building a plane and saying, yeah, the people who wanted it built this plane, we're going to let them fly. We don't really need engineers to like see if it's safe, and it's going to take off at this time.
Yeah.
It's going to run that airway, and let's see where it goes, like down the runway. And that's basically what happened with MAiD in Canada. And I am sure, and I encourage all citizens and all people to be aware. None of us were aware, while our colleagues who were pro-assisted dying were getting into the colleges. They were getting into places of influence. They were getting ready for even the next steps of expansion. We were not ready. We were late to the party they planned. And so a lot of them are controlling the safeguards and the oversight of the safeguards, and a lot of them drafted the model practice guidelines of how this would the CAMAP curriculum. So first of all, we were operating without a curriculum. So you could be a family doctor, any doctor and nurse practitioner could be a MAiD person with minimal training, and now they're trying to form a curriculum. But really, who's forming the curriculum are all the most radical MAiD expansionists in Canada, people who have been advisors to Our Dying with Dignity.
Yeah.
And they also have the voice. Their voice is the one that the government hears.
Yeah. Gosh, there's just so much in what you've told us. It's very salutary hearing what's been happening in Canada, and we just do so appreciate you coming over to Scotland to tell us about it. I think many of us have probably not appreciated how significant it has been in Canada and the changes that have been brought, and I suppose how adversely it's affected those who are marginalised. And I think you've really helped to draw that out and illustrate that to us today. So we really appreciate that.
I actually have one thought I want to add in like 20 seconds.
Of course.
A lot of Christians find that their voices are marginalized in this debate. Do not let them marginalize your voice. You are citizens, you belong in this debate. I know that there might be many people of a religious affiliation on this, listening to this webinar, and it is because you have a reasoned, well thought out philosophy that is guiding your beliefs, and you're right. It's taken many of us, many agnostic people, atheists are now on side, but you guys actually have a lot of wisdom in your traditions. Do not abandon that. Lean on that.
Thank you. And there's a real breadth of people who have huge concerns now with the way that things have developed in many countries. And thank you so much for illustrating it as well. I think sometimes we can read, but no, it doesn't hit home, but it's been really helpful to think about that. So thank you so much, everyone, for joining us. We really appreciate your time, and we do encourage those, if you are local, there is a meeting in Edinburgh and next week. And those of you who are able to make that, you would be most welcome to help equip us more to speak to those who have decision-making power in Scotland. So thank you so much, everyone, for joining us, and thank you again to Ramona, and good night and take care.